Do you think we need to try to standardize MRD testing, though, across the country?
I don't think it needs to be
adults?
standardized. I think the individual providers of MRD testing can validate their tests. They can apply for FDA approval of their tests to show that it's reproducible, that it's valid. I don't think we need to have everyone do the same MRD assay. Again, because flow cytometry, ASO-PCR, next-gen sequencing, they correlate very, very well. So I don't think we need to standardize. And I want to enable MRD testing for all patients. And so again, if you've got a flow-based assay, in your hospital, by all means use it. You want to, have as minimal barrier to doing the MRD testing as possible. But for the physicians that don't have access to an internal flow-based MRD assay, I think you really need to set up a way to send it out to Adaptive for the clonoSEQ assay.
And I guess, Bijal, you're saying, because I always wonder, could a test be too sensitive? Mm-hmm. Could we be picking up a few small clones that are quote unquote irrelevant? It's not going to change the patient's prognosis.
Exactly, and I think, but that's my. We know that pushing beyond 10 to the minus 4 in Philadelphia positive ALL is relevant. I suspect, not just suspect, the UK ALL data that was recently published also demonstrated using allele-specific PCR that pushing below that 10 to the minus 4 threshold was also prognostic. So I have a sense that as we go deeper, it's going to be relevant, but at some point, without question, the signal-to-noise ratio is lost, right? We start picking up on more noise than signal, and we also see that in the Philly positive patients, right? What do you do with a PCR of 0.000006? I mean, I tell you what I do. I repeat it. So, but you're not really sure what to do when you approach that level.
I think at those lower limits, it's likely going to be stratified by the genomics of the disease. If a patient has a pH-like lesion and they get to 10 to the minus 5, that could mean something different than somebody who has normal karyotype, no genetic lesions that are identified on genetic profiling at diagnosis. We're going to need very large studies to help disambiguate that, but there has to be some interaction between the genetics of the disease and their MRD achievements at various milestones, and we don't understand that quite yet. So in some cases, we might have too much knowledge if we use a highly sensitive assay. In other cases, that knowledge about the residual disease at a low level is vital. An example is in the post-allograft setting. We did a study when I was at Stanford showing that any detectable disease, even at the 10 to the minus 6 level, forecasts that those patients are all going to relapse. So I think, in that particular setting where if that patient relapses, it's going to be very hard to capture them again and offer them anything meaningful for long-term disease-free survival. That's a scenario where I think the stakes are high and using the more sensitive test is very well justified.
But I think we also need to talk about why we're having this discussion. Right? I mean, and I think we're going to get to it later as well, I hope, but because of what we're seeing as it relates to blinatumomab in the context of MRD, because of what we're seeing as it relates to CAR T-cell in the context of MRD, we're seeing superior outcomes with less toxicity. And I think we have to account for that, and that's the reason why we need to think about it. It's not to say that it's not making transplant irrelevant, but it's simply saying we have a technique that can that we can now utilize in the context of MRD.
Well, I think we're getting into a very interesting era because, historically the presence of MRD at one of these milestones was used to intensify therapy, give some more chemo, make sure you get them to transplant. The BLAST study demonstrated that for MRD patients at week 16 who got 4 consecutive cycles of blinatumomab, they had 50% long-term disease-free survival without being allografted. Now that's a small study, it needs to be repeated with a larger number, but that's really compelling that there may be patients that if we could identify them, if we treat them for MRD with an immuno-oncology agent like blinatumomab, perhaps we actually save them the need to go to the transplant, which is very, very interesting. And we'll end up with these scenarios where patients who do well, achieve their MRD negative milestones, actually are going to stay on chemotherapy and chemotherapy maintenance for 2 to 3 years, and those who are MRD positive at week 16 are actually going to switch tracks and get some blinatumomab and be done earlier.
Exactly.
Which is like, is that right? I don't know how we're going to deal with that as a field, but that's what the data now are telling us to do. So it's going to be really interesting.